we're here with a lot of friends today. It's a pulmonology morning report, and we have friends from University of Washington joining us today. So I'm going to give some brief introductions to get us started. So our case presenter today is Dr. John, who is a Pulm Fellow in the Clinician Educator track at University of Washington. She completed her medicine residency at Mount Sinai in New York, and her professional interests include survey design and implementation, curriculum design, and QI. And our case discussants today are Doctors Choruh and Stiller, Choruh and Stiller, I'm sorry. Dr. Choruh is an associate professor of pulmonology and the PD of the Pulm Care program at UW. She's a clinician educator who is active in undergrad, graduate, and continuing med ed, and her interests include curriculum development, coaching, and leadership. And finally, Dr. Stiller is a senior Pulm Fellow and part of the clinician educator track at UW as well. She formerly served as a chief resident at Harborview Medical Center in Seattle and is interested in professional development during chief residency. So with all of that, I was wondering if Dr. John could start by quickly talking about what you like to do outside of medicine and then what led you into pulmonology.
Sure. Things I like to do outside medicine. I bake a lot, as Robin and Başak can attest to. I like hiking. Now that things are opening up a little bit, I enjoy exploring new restaurants as well. As for why I chose Pulm Crit, I love the physiology, I love the teamwork, I love the multidisciplinary care, both in the ICU and within pulmonary. I could go on, but I'll stop with those three for now.
It's wonderful. Thanks for sharing. Next, Dr. Stiller.
Sure. Outside of medicine, Seattle's an amazing place. I like to run, hike, make the most of the water in the mountains that are nearby to us. And I went into pulmonary and critical care in part because my dad's an intensivist. And so I spent a lot of my growing up life talking about it. And then I met Başak like my second month of residency. And I guess that's how we got here.
Wonderful. And then finally, Dr. Choruh.
Thanks, Andrew. So outside of medicine, I have a toddler who's, well, not a toddler, a 5-year-old who keeps me very busy doing 5-year-old things these days. So I do a lot of early reading. Outside of that, though, I love to bake. I'm not as good of a baker as Mira, but I do really enjoy baking. And my husband and I really enjoy cooking large feasts of Turkish food. So large parties. We haven't gotten to do that a lot during COVID, but we both enjoy cooking a lot. And then I don't know if I have anything unique to add to what Mira and Robin have already said about pulmonary and critical care. It is, I took a really winding path to medicine and dabbled with a lot of different specialties, and then realized that in pulmonary and critical care, I get to do all of those things. I get to think about all of the organs. There's a lot of end of life care. I love working in teams. I love physiology, like Mira mentioned. So if anyone is interested in pulmonary and critical care or unsure of kind of what step they're going to take next, I'm happy to chat.
Thanks so much for being here. We really appreciate it. So before the case getting started, we also have some friends from the CPS team helping us out. Do you all want to introduce yourself really quick?
I'll go, I guess. I'm Mukund. I'm a second-year medical student at UCSF. I'll be doing teaching points today.
Oh, hi. I had to say Mukund, sorry. Hi, everyone. I'm Jasmine. I'm a Mexican IMG, and I'm going to be scribing today.
Perfect. And Rafa's here helping as well. I don't know if technically he's doing anything, but Rafa's here, and Amanda and Deborah as well. But okay, we can get started then if we want to just pull up the whiteboard. So we have our blank slate here, and we'll have our case presenter start with Aliquot 1 when we're all set up. Beautiful. Okay, so whenever you are ready, Dr. John.
Okay, so I am presenting a case about a 50-year-old man presenting with hemoptysis. So he presents with one episode of about 1 cup acute hemoptysis that occurred just after he completed a rowing class. He describes this as an episode of coughing up blood that was dark red. He thinks there were clots, but he's not sure. He's had prior mild episodes coughing up like a little bit of blood, as well as nosebleeds. The prior episodes were thought to be related to the nosebleeds, and he actually had an upcoming appointment with ENT before coming in now. He denies recent fevers, chills, shortness of breath, chest pain, denies night sweats, denies lower extremity edema, denies decreased exercise tolerance. He actually is very active. In addition to rowing, he jogs, he works out at the gym. He denies nausea, vomiting, bowel changes, joint changes, new skin findings. He's lost 50 pounds over the past year, but this was mostly intentional, again, in the setting of being very active, watching his diet, etc. Would you like any
Yeah.
more information?
I'll leave that to the discussants at this point, and you two can tackle this however you like. I don't know if one of you wants to handle one aliquot or both of you comment. I think typically both people like to comment, but I'll leave it up to you two. It's very interesting.
Yeah, Robin, would you like to start and then I can
Sure.
tag on?
Sure. All right. So here we have a middle-aged man who's coming in with what is striking to me. I think I heard you say, Mira, 1 cup of blood that he coughed up. So there's a couple of things that are initially coming to my mind. The first thing, Mira, I'll ask you at some point to tell us is just when you're looking at him, I'm curious to know how he looks to you, how he's interacting with you, how he's able to talk to you, sort of what he is looking like right in front of you. And then some other thoughts that I'm initially thinking about are, has this ever happened before? So you said something about prior cases have been attributed to nosebleeds. So learning a little more about what those prior episodes have looked like, what workup has been done to investigate that, if any. And then eventually I'm interested in getting into some past medical history and learning more about other medical conditions that this patient may see doctors for or be treated for, and go from there.
Sure. So he actually looks pretty well appearing given his reported symptoms. He's speaking in full sentences, not actively having any episodes currently, can give the full interview. This is the first time it's been a quote large volume, I guess. He's had small like specks or very small blood clots before, has not had a workup yet. Again, I think he was referred to see ENT for nosebleeds because initially the prior episodes were thought to be around when he would have a nosebleed. So it was thought the two were related. This time he's not having a nosebleed.
That's great. And I'll maybe add a few things in terms of maybe how I might approach this problem, because Mira, I'm curious to get a little bit more data too. I think when I hear about hemoptysis, so I just start kind of thinking about some big buckets, and I think about this is one place where I actually think about things anatomically rather than anything else. So anatomically, I start thinking about first just oropharynx and confirming, is this actually hemoptysis? Because I think we've all been fooled by someone who's having hematemesis, and it turns out it's not coming from the lungs at all. So what you've described certainly sounds like hemoptysis, but we'd want to tease that out. And then thinking about a big bucket of kind of, is it an airway problem? So wanting to know if he's been sick, has he had bronchitis? Does he have history that supports that he might have bronchiectasis? Does he bring up a lot of sputum at baseline? It doesn't sound like it based on what you've told us, but we'd want to kind of explore that. Could he have inhaled a foreign body? Could he have, he's 50, could have a airway-based malignancy that could cause bleeding? And then going down further into kind of parenchymal causes of bleeding, does he have some infection? I saw someone in the chat was asking about travel. So TB can certainly cause hemoptysis. Invasive fungal infections can cause that. We'll hear a little bit maybe more about, does he have risk factors for unusual infections? And then other things in the parenchyma that kind of go along also with vascular might be, could there be a vasculitis or some sort of vascular abnormality? You mentioned nosebleeds, so something like hereditary hemorrhagic telangiectasia that could results in some AVMs in the lung and maybe some, recurrent nosebleeds or bleeding in other places. So I'd want to know, has he had bleeding before? And then in addition to AVM, so, pulmonary embolism, if it causes infarct, could also cause hemoptysis. So those might be the big buckets I'm thinking about. I don't have a great differential for hemoptysis that occurs during rowing. So I'm going to try to take that out of the equation for now, and we'll just hear a little bit more from you in terms of the history.
That's wonderful. And since we have such a good overview of hemoptysis before we even move on to the rest of the information, I was wondering if someone could comment on kind of base rate of these etiologies. Like, is there one here that's super common that we should be aware of and kind of top of the list, or at least like a top 3 lists for hemoptysis?
I can't quote numbers for you, Andrew. I think, universally, if you're looking at hemoptysis, the number one cause by far is just simple bronchitis. Someone has a viral infection, they have some airway irritation, and they have hemoptysis. I think another thing we'll want to tease out in this is what Mira described sounds certainly like massive hemoptysis. A cup of blood is a lot of blood. And we're not hearing that this is like blood streaked sputum. We're hearing just frank blood. And so when I hear of kind of massive hemoptysis, that changes the differential for me a little bit. And I start thinking more about things like either bronchiectasis or a vasculitis or an AV malformation. A little bit of the volume can be helpful. There's kind of 2 circulations that supply the lung, the pulmonary circulation, which is under really low pressure, and that tends to not cause significant bleeding. But then the bronchial circulation, which supplies the airways and can get hypertrophied in folks that have bronchiectasis, that comes off of the aorta. So that can cause pretty significant bleeding. And I guess based so far on what I've heard, I'm concerned that we're in that massive category.
That's so wonderful. Thanks for explaining that. So with that overview, I'm sure the next aliquot is going to be very helpful as we can pivot things a little bit, perhaps. So what do we have for aliquot number 2, Dr. John?
Sure. Okay. I can give you a bit about his background. In terms of past medical history, he was diagnosed with GERD a while back. He also was diagnosed with sarcoidosis of the skin and lung. I'll talk a little bit more about that in a bit, but very quickly, no recent surgeries, no allergies, notably not on any medications currently. He's not on anticoagulation or painkillers or blood thinners or over-the-counter supplements. He's not on immunosuppressants or other medications that could affect the immune system. He lives by himself in an apartment in a quote old building with leaky pipes and likely mold, though he's not sure. No prior tobacco or alcohol or other substance use. He works in retail, denies exposure to asbestos, does not have pets, no recent travel. Başak, there was another question that you asked and I'm blanking on it now.
Just risk factors for unusual infections.
Yeah. Giving a little bit more information about his sarcoidosis. This was diagnosed via skin biopsy over a decade ago. He was told that he had, quote, lung findings on a CT scan a few years ago. He's also had eye involvement and was a few years ago treated with prednisolone droplets and systemic steroid therapy, but has not had a flare in years and currently is not on anything. Regarding his lung involvement, he, again, was told he had lung findings on a CT scan about 5 years ago, underwent PFTs then, which were reportedly normal. From what you are able to glean from his records, because he's never been seen here before, he did establish care with pulmonary a couple of years ago. His PFT showed a total lung capacity of about 70% predicted and a DLCO about 55% predicted. And those were stable both 2 years ago and last year. He also reported a cough 6 months ago and was trialed on an inhaled corticosteroid, which he self-discontinued a couple months before presentation because I'm not sure why. Either his symptoms got better or he wasn't getting relief. He's not reporting a cough now. He's not reporting increased sputum production. And again, this is limited review since we do not have access to his other records. oops, I can go into his physical exam if you'd like.
I think that's a lot of really good info we can kind of manipulate for now. Yeah, I'll open it up to our discussants here. That's a lot, and I'd be very curious to hear at some point in the discussion kind of about the PFTs as a review. I think would be helpful for a lot of us here.
Okay, so learning that things that stood out to me, obviously the sarcoid and its multi-organ involvement that we'll get to, but I think the GERD is relevant too, because as Başak mentioned, sometimes we do get fooled as to where bleeding can be coming from. And then Mira, you did a great job of sort of excluding all the other low-hanging fruit, like if he's on a blood thinner or something that would predispose him to abnormal volumes of bleeding there. I think in fellowship, I have certainly gained a healthy respect for sarcoidosis because it does whatever it wants, whenever it wants, wherever it wants, and it appears in all sorts of ways on imaging and otherwise. So I think that that obviously is sort of the most striking thing that he, you're telling me that he's already had involvement in multiple organ systems, but sorry if I missed this. You said he's had steroid eye drops and used an inhaler one time, and that is the extent of medicines that we know that he has received in the past?
Yes, and this was all like not in the recent past. The steroids were years ago, we don't know when. The eye droplets also were years ago, we don't know when, but not recently.
Okay, and that's really interesting too, that if sort of he was totally healthy, absolutely nothing, he had no progression or increase in symptoms, there was no clear trigger or something that is known to him to be a trigger for his symptoms, and then all of a sudden out of nowhere he had this very dramatic and emphatic presentation with a lot of bleeding. So that makes me definitely want to also maintain a broad differential. I have this thing that's right in front of me that I'm curious about as far as his pulmonary pathophysiology, but it just sort of came up out of the blue for this guy who otherwise was healthy. So it makes me want to make sure that I'm not anchoring on that and try to continue to think broadly about what else could be going on in someone who has this at baseline.
Yeah, totally agree. I don't know that if how much we've narrowed things down other than perhaps we're not hearing that he's at least currently immunocompromised that we know of. And if he's not, then hasn't had other exposures, then infections like TB and invasive fungal disease might be a little bit less likely. I do think his 50-pound weight loss, while intentional, is still notable, and a lot of chronic illness could go along with that, whether it's malignancy or, again, I think something like vasculitis, something like GPA, where we can tie together potentially kind of nose epistaxis as well as hemoptysis. So I would still keep that in the differential, I think. Someone asked a really great question in the chat about, how do you approach the volume of hemoptysis, and do you decide if it's massive or not massive? And I'm not aware of a great way to do this. There's kind of varying numbers that are reported in the literature, ranging from like 200 mils in 24 hours to 600 mils in 24 hours. And, I don't always think in terms of, oh gosh, that's 540 mils of fresh blood. So I think it's a little bit of your instinct when you see the blood and noting that it is frank blood that someone is coughing up rather than just blood streak sputum. I'm also intrigued by sarcoid. As a history item, I agree with Robin. I have been fooled by sarcoidosis so many times. It's not a disease that I classically think of as presenting with hemoptysis. It's usually not so much airway involvement. And then Andrew, to get to your question about PFTs, I don't know if I can do justice to PFT interpretation in 30 seconds, but I'm going to try. So first, maybe starting out by, and we don't have this data, but my first question when I look is there evidence of airflow obstruction? So looking at the FEV1 to FVC. We don't have that, but I feel like Mira would have told us if there was airway obstruction. So I'm going to assume this person does not have airflow obstruction. So making us less worried about airway diseases like COPD, asthma, bronchiectasis. And then the second step is to look at the total lung capacity to ask the question, is there restriction? And a TLC of 70%, it's less than 80% predicted. So that does qualify as mild restriction. That could be for a lot of reasons, including it's effort dependent. So maybe it was just not a great effort, but potentially there's some restriction, and sarcoidosis can cause fibrosis and restriction in the lung. And then step 3 is to look at the diffusion capacity. to get a sense of what is the surface area for gas exchange. And here we see that it's only 55% predicted. So there's decreased surface area for gas exchange. That could happen for a number of reasons. It could happen on the alveolar end. Maybe there's fibrosis from sarcoidosis or something else going on the parenchymal side. DLCO can also be low because of a problem on the vascular side. If there's pulmonary hypertension associated with a sarcoidosis or some other vascular problem. So I'm still, I would say, relatively undifferentiated. I'm with Robin on this. I think we need a good exam and then some baseline labs and imaging before we can go further.
Let's get some baseline labs and imaging and then an exam. That sounds good.
Okay. So on exams, I'll start with vitals. He is afebrile, 36.4 Celsius, blood pressure 120/88, heart rate 101, respiratory rate 22, satting 99% on ambient air. He appears, he's middle-aged, well-appearing, appears as stated age, not in acute distress, is speaking in full sentences, does have some small flecks of blood on his shirt from his earlier episode. He is normal, his mucous membranes are moist. He does not have any oral pharyngeal lesions. His nasopharynx does not look like there is dried blood there. His cardiovascular regular rate and rhythm, though again 101 on the vitals, no murmurs, rubs, and gallops. Pulmonary exam is notable for mild expiratory wheezes, but otherwise clear. And he's moving air well. GI exam, he has bowel sounds, he's soft, non-tender, non-distended. Extremities, he's warm and well perfused, no lower extremity edema. And his neuro exam and his skin exam are also non-focal. I can move on to labs whenever y'all are ready.
Yeah, I think some basic labs could be helpful here too. Let's go through those too.
Sure. Okay, so we'll start with his BMP. His sodium is 135, potassium 3.9, chloride 104, bicarb 25, BUN 16, creatinine 0.81, glucose 89. His CBC, his white count is 5.27, hemoglobin is 11, hematocrit 34.2, platelet count 269. We don't have a baseline, unfortunately, since this is his first time here. I have some more stuff from his diff if you would like. His MCV is 87. Within his diff, he has 71.3% PMNs, 11.8% lymphocytes, 3.2% eosinophils. I don't have an absolute count with me, unfortunately. His INR is 1.1. He has a negative troponin, a negative BNP, a UA that was unremarkable. His LFTs also were unremarkable, normal billies. And I don't have a chest radiograph, but I do have a chest CT that was done on admission or in the ED.
Okay, maybe we'll stop here with the exam and labs really quickly. I'm not sure how much progress we'll make, but let's just at least pause here for now.
Good point. I'm not sure how much progress we'll make from here. What has stood out to me the most is actually that he is anemic to begin with. So I'm curious about that. He had this acute blood loss on that day right before this, but at baseline, it seems here, or as he's coming in, he certainly has some anemia that needs further investigating. That's my attending is right here. I'm going to get some help with the case.
Oh, okay.
But the other thing that is really important to me right now is that this patient is well appearing and not in distress. You know, when someone has blood in their airway or blood around their airway, that obviously we want to feel extra confident that our patient is able to protect that airway. And patients do a better job doing that on their own than we are able to if we try to take control and protect their airway on their own. And meaning that sometimes it is the instinct to say, oh, I have to intubate a patient who is bleeding from their airway because we get scared that it's going to get obstructed or blocked with a clot or something like that. But a patient that's interacting with you and able to generate a robust cough, they are going to do a much better job of getting that blood out of there and maintaining a patent airway than we would be able to through a ventilator or through a breathing tube. So those are kind of really important points that come to my mind when it comes to hemoptysis.
I completely agree. I was equally reassured by your description of the exam mirror. I think hemoptysis can be really scary, and that decision of, is this person going to be able to protect their airway, is probably the first thing that we think about, especially with massive hemoptysis. And what you've described is that he actually looks okay. And just as Robin said, we want him to be coughing out this blood on his own rather than us intubating and not really being able to clear the airways. You know, the other thing on the exam that I sometimes look for is there a way for me to kind of just localize with my exam where the abnormality is? Do I hear some abnormalities on one side versus the other? Because we do think about positioning a lot with hemoptysis, especially if someone is having massive hemoptysis, thinking about actually trying to put the bleeding lung down so that if the bleeding is continuing, then it's contained and it's dependent and it's not going to drip into the other lung and cause problems there. I also want to learn a little bit more about this anemia. I don't generally think about, you know, hemoptysis in general. People aren't going to be exsanguinating and losing lots and lots of blood. The main concern with hemoptysis is actually asphyxia, that you could basically flood the alveoli with blood and they won't be able to oxygenate. And that's going to be what's going to cause morbidity and or mortality. And then I think there is one thing that is a little bit helpful as we were thinking about those big buckets, and we said in the parenchymal category, we think about vasculitis. So a lot of forms of vasculitis can cause pulmonary renal syndromes where you see both hemoptysis as well as some renal abnormalities. I'm a little reassured that this person has a normal creatinine. I think we would still want a urinalysis to make sure that there isn't blood in the urine that would again make us think about something like GPA or Goodpasture syndrome or something like that. I think otherwise we just need some imaging to see what's going on in those lungs.
Yeah, I'm sure we're gonna have some very interesting slices. Let's see this, Dr. John. I'm very excited.
Sure. Is there a way I can share the imaging? If not, I can describe it.
Could you do the share screen function at the bottom of your screen? Do you
Yes.
see that? Try
Yes.
that.
Let's try it. Okay, can everyone see
There
my
we go.
screen?
Perfect. Oh, wow.
I can, oops, there we go. I'll play it again. Okay, I'm gonna stop my share.
Well, what are we looking at here? I think before we get the read, I'm wondering
Yes.
if our discussants can tell us kind of what we're dealing with here.
Well, you gave us a quick drive-by, but I saw something that was circular and very dark inside. So thinking about what is really dark, what is really bright on the left side. On the right side, I definitely saw some denser areas of consolidation. We'd have to maybe go back. It was, again, a quick drive-by, but really this lesion on the left side is what stood out to me first and foremost, but then noting that there was plenty of abnormal parenchyma on the right as well.
I'm trying to go back, but as I do a slower thing, I'll tell. The read showed a right upper lung, subsolid opacities may represent pulmonary alveolar hemorrhage, given patient history, mid-lung perihilar fibrosis, which can be seen in sarcoidosis, bilateral cavitary lesions concerning for mycetoma, though also can be seen in sarcoidosis, no active evidence of active extravasation. They also did it as a PE study and did not see evidence of a PE.
Okay, great. And my one question for you in looking at this, Mira, I agree there's just areas that look like they have right around here that look like fibrosis, and then what also looks like traction bronchiectasis. The airways just look abnormally dilated in a few places. And I was curious with that left lesion, I can't quite tell if that actually connects to airways and is an area of cystic bronchiectasis, or if it's just a separate cyst. And it sounds like they're reading it as potentially a separate cyst.
That was how they read it as, yes.
Okay. So I think this is helpful. We definitely have some parenchymal abnormalities. When we talked about infections that can cause a hemoptysis, so invasive fungal disease is one form. Another form is actually having an aspergilloma or a mycetoma, where someone has pre-existing lung disease. In this case, this individual has sarcoidosis, and they have abnormal lung architecture, which allows for a cyst to form and for a fungus ball to get in there. Usually an aspergilloma, but it can be other fungi as well. And he certainly has abnormal airways and parenchyma. So I think that is going to certainly be a risk, is the bleeding coming from that site. Again, there's also bleeding though that could come from areas of bronchiectasis, and this individual also has areas of bronchiectasis. So that could also be a cause of bleeding. I think there's probably a few ways that we could proceed here. And maybe Robin and I can tag team on kind of what we might pick in this case, but I think in general, one option might be to do a bronchoscopy to see if we can actually localize where the bleeding is coming from. Is it coming from that side with the cyst? Is it diffuse and coming from multiple areas? Another option might be to get, again, you've gotten some CT with contrast here. This was a PE study, so not maybe exactly timed, but another way would be to get some imaging, an angiogram, and see if we can see active extravasation. And then another option might be to think about partnering with interventional radiology colleagues and having them actually take a look and see if they can see where the bleeding is coming from. And the benefit is that they can then also do something about the bleeding. If this is bleeding from the bronchial circulation, which again, if that's a cyst that has bronchial vessels going to it, that could result in a lot of bleeding, and perhaps that needs to be embolized. Robin, what do you think? What would you recommend in this case?
Yes, that is exactly how I think about it as far as next steps. I think my first inclination probably would be to pursue the CT right now. I think that's probably where I would start. Again, sort of coming back to the fact that I know my patient is in a clinical position where I think he could tolerate the scan. So that might be one thing. That doesn't limit it to just the scan. That's an important thing to consider for an intervention as well. But I think obtaining that imaging to help guide is probably where I would start.
Okay, so he does undergo repeat imaging, but again, it was suboptimal timing, so it doesn't give any new information. He does undergo a bronchoscopy with BAL from the right middle and right upper lobe, and there was no active bleeding noted at the time. Cell count, diff, lots of infectious studies were sent out. The team did talk with thoracic surgery and interventional radiology as well to alert them of, hey, this patient is here for hemoptysis. Early the next morning, however, he has an acute episode of large volume, this time a liter, of frank hemoptysis causing acute desaturation. And I'm curious about what you would like to do next for him as this is happening and as his studies are all cooking. / what studies would you ideally order?
So this is definitely a contrast to how he came in, and this is making me a lot more concerned. If now, the volume is increasing. So if I'm thinking about a source, this is further supportive of this is a higher pressure blood circulation source that this is coming from. Not that we didn't suspect that beforehand, but just sort of further supporting that. So volume is increasing, and now he's having other sequelae that are putting him at risk. He's desaturating. And Mira, you can tell us sort of if he's still able to, you know, what he is looking like as far as communicating with you, mentating, protecting his airway, that sort of thing. But this is starting, obviously, to make me very nervous, given that things are progressing, despite the fact that we didn't see anything on our initial, or anything terribly revealing on our initial workup.
This time he is struggling and very much in distress.
So I think at this point, so a liter of blood, I will say, I don't think I've seen a lot of massive hemoptysis. I don't think I've ever seen a liter. That is a lot of blood. And it sounds like he looks quite unwell. So I would say we are definitely at the point where we do need to secure his airway to keep him safe. So I would move towards endotracheal intubation. And I think I would place him left side down. I'm going to assume for now that that large cavity on the left is where the bleeding is coming from, even though we haven't been able to localize it. I think once he's intubated, I would do another airway inspection to see, can we actually see where the blood is coming from? Again, there's some other things that we can do. Sometimes you can place bronchial blockers to try to kind of isolate the part that's bleeding. I think that's going to depend on what you see with your bronchoscopy. In terms of kind of thinking again about your differential, where is all of this coming from? You mentioned a lot of the infectious studies are cooking already. I would send all of the workup for vasculitis, so ANA, ANCAs, make sure that we're not missing something autoimmune that he might have in addition to the sarcoidosis. I think this is less likely, but another, you know, when we think about kind of the vascular bucket, you can see hemoptysis with elevated left-sided filling pressures. I wouldn't expect a liter of blood and for it to be frank blood, but I would at the very least do a bedside cardiac ultrasound and make sure that his cardiac function is normal. He also has sarcoidosis, which can also affect the heart and have impacts there. So I would want to know that his cardiac function is okay. And then it really is a little bit of waiting to see what we can do next. I think we do now more recently have some inhaled therapies that we've started using, inhaled tranexamic acid or aminocaproic acid. So using antifibrinolytics as a way to kind of try to mitigate some of this bleeding. But what you're describing is such high volume that I think we're going to need to embolize whatever vessel is bleeding.
So pulmonology is not my wheelhouse. I'm reviewing Dr. Nick Mark's one-pager on massive hemoptysis as y'all are talking about this right now. And I was wondering if you could comment on intubation strategies briefly, just like keeping it super simple. Like I'm reading that there's like a main stem intubation, something about like a bronchial blocker. Could you all comment on that briefly?
Robin, you want me to take this one? Okay, so these are all just ways of just thinking about, normally when we intubate someone, we're placing the breathing tube into the trachea. So it's sitting in the trachea and then we're getting gas exchange from kind of both lungs. So if you know that the problem is in one lung or another, so for example, if we knew here, and again, we suspect that the bleeding is coming from the left side, you could say, I'm just going to selectively intubate the right mainstem bronchus so that all the gas exchange is going to take place through there. And we're just going to leave the left lung out of it and prevent blood from coming into the right side of the lung. And similarly, bronchial blockers are just devices that, again, help you kind of isolate portions of the lung. There are also dual lumen endotracheal tubes that in general are terrible, but I think all of these are just temporizing measures. These are all just ways that we're temporizing until we can definitively treat the thing that is bleeding. So I think in this case, we're not even sure where the bleeding is coming from. I think this would be just kind of a normal intubation, and then we would perform bronchoscopy to inspect the airways, see if we can find the bleeding. And if we saw, oh my gosh, there's a lot of blood coming up on the left side, maybe that's when you would say, you know what, I'm going to just intubate the right lung and just ventilate that lung until I can handle what's going on the left.
That's awesome. Thank you so much for making that simple for us. Okay, I think we're nearing the end, I suspect. I'll leave it to you, Dr. John. I'm not sure how many aliquots you have left. We do have plenty of time if you want to break it down a little bit slower. I totally leave it up to you, though.
Sure. Okay, so yes, he does get intubated at this point. And then once his airway is secured, he does go down for a repeat scan. I can show that to you if you would like, since we do have a little bit of time. Let me see if I can pull it up. Sorry. let's see. Oops. Sorry, my computer's. Nope, oops. Okay, can you see my screen?
Yep.
Oh, this might be the same one. There we go. Nope. Okay, I can give the read as well.
Sure. I don't know if I saw active bleeding as you were scrolling past. It looked pretty similar to the scan that we saw before.
Yeah. Again, they couldn't identify a source, at least from this, and at least from this scan. But we did do the bronchoscopy. When we did do the bronchoscopy, it did show active bleeding in the right upper. So at this point, he goes down to radiology and undergoes embolization, which stops the bleeding. And around this time, this is when we finally get some studies coming back. He has his BAL has a positive galactomannan, positive fungal PCR for Aspergillus fumigatus. He also has a positive serum galactomannan, positive beta-D-glucan. So he is eventually started on antifungal therapies, and eventually he is stabilized and extubated. Our final diagnosis is pulmonary aspergillosis, concern for invasive.
So that's fascinating for a few reasons. I think one, you know, in hearing this story, when I think about kind of risk factors for invasive fungal disease, I think about people that have prolonged neutropenia, which actually isn't that prolonged. It's just 7 to 10 days of neutropenia. We didn't hear that he was neutropenic. We didn't hear anything in his history that he has a qualitative problem with his neutrophils not working. And he's not on immunosuppression. And so when I think of what, you know, aspergillus can do in the lungs, there's this whole spectrum that goes from it can sit in a little cavity in your lungs where it's kind of contained, to kind of a chronic aspergillus infection, to what we fear, which is what you're describing, Mira, is this invasive fungal infection. And you know, I haven't heard a lot in his history that would go along with that. The galactomannan test that we perform on bronchoalveolar lavage, that you can get a false positive on that in folks that are having active bleeding. If there's a lot of red blood cells in the sample, but you're saying the fungal PCR is also positive, the serum galactomannan is also positive. So it's clear that he has this fungal infection. I think it's curious that I don't know what his risk factor was for developing this infection.
And that was our question as well. So we wonder if maybe this had been a chronic thing. Again, he was told he'd had abnormal CT findings before. Was this there? Was his weight loss related to it? When he was on steroids a long time ago, did that put him at risk? Many questions, but yes, it was a very unusual presentation.
And how did he do, most importantly?
Well, his bleeding stopped after the embolization, so.
That's fantastic. So I think one other teaching point about embolization that comes up, not maybe in this case, but often when we're doing bronchial artery embolization, is in folks that have severe bronchiectasis, and cystic fibrosis is kind of the hallmark disease that we think about. And we're seeing more and more individuals with cystic fibrosis now that we have these amazing drugs. These folks are living longer, and we're seeing more episodes of people coming into the hospital with massive hemoptysis. And one of the risks of a bronchial artery embolization is that we can actually worsen gas exchange. So there's some evidence that those bronchial arteries actually help, that there is some gas exchange that happens on the bronchial side. And so if we take out that circulation, we've had patients develop hypercarbic respiratory failure after undergoing a bronchial artery embolization. And I think in his case, his lung function, as far as we can tell, was pretty good coming into this. So that makes it less likely, but it's a concern if someone has advanced lung disease. So that's great that he had a good outcome. And I imagine he's going to have a very prolonged treatment, phase-all treatment for his invasive fungal disease.
We have a surprise guest, Dr. Swenson here, as a fact to share.
Başak, and the rest. I believe it was Mira who published a case of just what you were describing, and that is someone with such otherwise severe lung disease of cystic fibrosis, patient with cystic fibrosis, and they bronchial embolized his bleeding lesion, and he went into severe hypercapnic respiratory failure because of just what you said, is that the bronchial circulation can take over quite a bit of gas exchange, particularly when it's anywhere from 10 to 30 times its normal flow, which usually happens in areas like this where there's such hypertrophy of the bronchial circulation.
One other thing, Başak, I think maybe you said something that made me think of this earlier about getting a sense where the bleeding is coming from. And in those patients that you're referencing, those folks with cystic fibrosis who have a lot of bronchiectasis and come in with kind of less bleeding than this, but we see these folks in the hospital who have bleeding episodes, hemoptysis episodes. Sometimes they can tell you where they feel like they're bleeding from. They can say, oh, I feel it in, you know, some location, which can be helpful. And I found that fact to be very interesting when I learned it.
Absolutely. Yeah. And often in the case of individuals with cystic fibrosis, they'll come in and say, it's my right lung, and they're usually right. So we always listen to our patients.
That's incredible. I'm definitely using that one from now on. Had a couple of cases of hemoptysis. I've never thought to ask that. A final question that was asked a couple of times is any association between pulmonary sarcoidosis and this? It sounds like no, based off your initial eval, but has anybody seen anything like this before?
I mean, I think as Robin said, sarcoidosis can do just about anything in the lung. So I imagine if we did a search for sarcoidosis and hemoptysis, we would probably find some report somewhere. But in general, I don't think of sarcoidosis as causing a lot of kind of airway related disease, and hemoptysis as a presenting feature. And certainly immunosuppression from being on either high dose steroids or other immunosuppression for sarcoidosis could certainly put you at risk for developing invasive fungal disease or other things in the lung, but nothing specific to sarcoidosis. And Dr. Swenson, you're joining us as a guest, so please correct me if there is an association that I don't know of.
In my longish career, I think you're absolutely right. I haven't seen anything like this, so I wouldn't ascribe it just to sarcoid. One other point is that any area of lung that's destroyed is often fantastically fertile ground for just about any organism. So Aspergillus is a common species that we all inhale at times. And under the right circumstances, a fungus like this can just set up shop in an area like this. All the local defense mechanisms are lost. All the ability to make a number of these proteins that work against fungi and bacteria are often lost. So normal lung is the best lung to have to fight infection.
Yeah, I think this is quite the finale and such an awesome case because, invasive aspergillosis, of course, the association with hemoptysis is clear, but the sarcoid, it was very hard to link that until we had the final objective evidence. So a really nice kind of unusual manifestation of a not so uncommon process. Yeah, thank you everybody for coming. This was so fantastic. Any final thoughts from anybody and final questions as well from the chat?
I think I saw two questions in the chat. One was around, was a urine drug screen done? And I think that does bring up a kind of a good point of there is something in the differential for hemoptysis. Cocaine, when inhaled, can cause severe hemoptysis. There are definitely case reports of that. In general, I've learned from my EM colleagues on this. I've really moved away from using tox screens in a lot of different cases. One, because I think it leads to bias against patients, and two, because they are not perfect tests. Someone could have used a substance that doesn't show up on a tox screen, and something could be positive on a tox screen that's just a cross reaction, and it doesn't mean that they use that substance. Even if something is possible, it doesn't tell you they just used that substance. They could have used it a week or two ago. So I've kind of moved away from that, but I do think that's an important point in your history taking, is to ask about, was there any use of specifically inhaled cocaine, because that could lead to hemoptysis. And then I think I saw a second question around, would you get a high resolution chest CT to demonstrate bronchiectasis? And it's a great question, because that's usually the test that we recommend to look for bronchiectasis in terms of the slices that it gives us. But if you see bronchiectasis on just a regular CT scan, you already have the diagnosis. That helps you kind of tease it out if it's more subtle. And I think in this case, I think he already had probably a few CTs, and that was probably sufficient.
Thanks so much for the extra teaching. And thanks again. Any thoughts from anybody else who came? Dr. John, Dr. Stiller? No? Wonderful. Thanks again for coming. We have Mukund here to kind of summarize the teaching points that happened, and then we'll get out of here. Thanks, Mukund.
Yeah, sounds good. This was a really awesome case, and pulmonology is a weak point of mine, so it's always good to get some review on really interesting cases like this. We started off with a description of a differential diagnosis for hemoptysis, starting off by thinking about other causes of bleeding in the area and ruling out hematemesis, for example, in the oropharynx. And then we took an anatomic approach to looking at hemoptysis in the rest of the system, starting with the airways, for example, with a history of bronchitis, which happens to be the most common cause of hemoptysis, bronchiectasis or airway malignancy, and then moving on to thinking about causes of bleeding in the parenchyma, for example, infection, tuberculosis, invasive fungal infections, vascular causes, for example, vasculitis or arteriovenous malformations, secondary to hereditary hemorrhagic telangiectasias. We also talked about pulmonary embolisms causing infarct and bleeding as being causes of hemoptysis from the parenchyma. There was a really interesting pearl here around the difference between pulmonary vascular circulation as being low pressure as compared to the high pressure bronchial circulation that comes directly off the aorta, and to suspect bleeding may be coming from this cause, depending on the volume of the bleeding. We went on to talk about some basics with pulmonary function testing, starting off by looking at an FEV1 to FVC ratio as an evidence for obstructive pathology if that's low, moving on to talking about decreased total lung capacity as evidence for restriction in this case, which can be caused by sarcoidosis, and then talking about a DLCO as a measure of the diffusion capacity of the lung and isolating decreases in the DLCO to alveolar or vascular causes. We moved on to talking about management of airways with hemoptysis, first when this person was awake and was able to cough up their own blood, and then afterwards when they were intubated. And we talked about options including selective mainstem bronchial intubation and bronchial blockers as a way of isolating the tube into the healthy lung. Finally, when we discovered that this was a fungal invasion, a mycetoma, a cyst or a clump of fungus housed within pre-existing abnormal pulmonary architecture, we talked about risk factors for aspergillosis, many of which were absent in this patient. And I think the word is still maybe out on whether sarcoidosis plays a role or not. Since there was a paper that was put in the chat, really interesting, I'll have to read that afterwards. And we also talked about a couple of other clinical pearls, all of which were new to me. For example, that we might see false positive galactomannan tests in people with active bleeds, and that in people with bronchiectasis and hypertrophied bronchial architecture, that embolization in bleeds in these cases may actually interfere with gas exchange, as bronchial circulation can take over in some of these cases. So tons of information. I didn't get all of it, but I got some of it. And I thought this was an awesome case. Thank you so much.
Mukund, that was an incredible summary. I have no idea how you kept track of that while we were talking, but you summarized it beautifully. So thank you.
Mukund is the best summarizer. Thank you, Mukund, for helping us as always. And good to see everybody. Thanks to all for coming. Feel free to keep joining us. We have our weekly emails that come out. Thanks again, everybody. Take care.